Welcome to this training series for the team at JADE Wellness Center. This program, based on DDAP training regulations, is required for all employees of DDAP licensed facilities. The training consists of 3 parts. Part 1 covers tuberculosis, Part 2 focuses on sexually transmitted diseases, and Part 3 will address hepatitis. Each topic is critical for addiction treatment professionals, as understanding the connections between TB, STDs, hepatitis, and other health conditions like HIV and AIDS plays a key role in patient care and public health. HIV increases the risk of TB and certain STDs, and having an STD or hepatitis can heighten the risk of acquiring or transmitting HIV. Throughout this training, you will gain a deeper understanding of these interrelationships and how they impact your work with clients and the community. At the end of part 1, there will be a quiz that you must complete and submit. Once you've finished all 3 parts of the training, you'll be eligible for a certificate. Please speak with your supervisor for instructions on how to obtain your certificate once you've completed the series. This training is more than just a requirement. It's a vital part of how we contribute to keeping our clients and communities healthy. So please make sure to really pay attention throughout each section. The knowledge you'll gain here will help you be more effective in your work and ensure that you're providing the best possible care. So let's dive in and tackle this together. Tuberculosis has been a significant public health challenge for centuries, with evidence of the disease found in ancient Egyptian mummies indicating its prevalence in human history for thousands of years. For much of this time, there was no effective cure, and the disease spread widely, often affecting the lungs and causing severe long-term illness and death. Until the development of effective antibiotics in the 1940s and 1950s, there was little hope for curing TB. During this period, those with TB were often sent to sanatoriums where they received rest, fresh air, and nutrition as the primary forms of treatment. This practice continued into the 1970s, reflecting the limited options for managing TB before modern medicine. Significant milestones in the treatment and control of TB began with the discovery of streptomycin in 1943, the first effective antibiotic against TB. This was followed by the development of additional antibiotics, which, when used in combination, provided a more effective treatment regimen and significantly reduced TB mortality rates. The introduction of the directly observed therapy, or DOT strategy, in the 1990s further enhanced TB control by ensuring patients adhered to their treatment regimens, reducing the spread of the disease and preventing the development of drug-resistant strains. Today, TB is considered a curable disease, but its control remains challenging due to several factors. The global HIV epidemic has significantly increased TB rates because HIV weakens the immune system, making individuals more susceptible to TB infection and disease. Additionally, the rise of drug-resistant TB caused by incomplete or improper treatment presents a serious public health threat. Apathy and lack of awareness also contribute to delayed diagnosis and treatment, further complicating the efforts to eliminate TB completely. Despite these challenges, continued advancements in TB treatment combined with robust public health strategies offer hope for controlling and eventually eradicating this ancient disease. Tuberculosis is caused by the bacterium Mycobacterium tuberculosis. TB primarily spreads from person to person through the air when someone with active TB disease in their lungs coughs, sneezes, speaks, or sings, releasing tiny droplets containing the bacteria into the air. These droplets can be inhaled by others, leading to infection. However, while TB is contagious, transmission usually requires prolonged close contact with an infected person. It's estimated that about 100 hours of cumulative exposure to an infected person may be needed for transmission to occur. Several factors influence the probability of TB transmission. The first factor is how contagious the TB patient is. Patients who have a high number of bacteria in their sputum or cough, or who produce many droplets when coughing, are more likely to spread the bacteria. The second factor is the environment where the exposure occurs. Transmission is more likely in small, enclosed, or poorly ventilated spaces such as homes, dormitories, or public transport, where the bacteria can remain suspended in the air for a longer period of time. Finally, the duration of exposure is crucial. The longer somebody spends in close proximity to a person with active TB, the higher the risk of inhaling enough bacteria to become infected. Understanding these factors is vital for implementing effective TB control measures and protecting those at the greatest risk of exposure. To understand how tuberculosis germs enter the body, it's important to know the process by which the bacteria are transmitted to establish an infection. So, like I said, TB germs are spread through the air in tiny droplets when a person with active TB disease in their lungs coughs, sneezes, speaks, or even sings. When another person inhales these droplets, the bacteria can enter their respiratory system. Once inhaled, larger droplets are usually trapped in the upper respiratory tract, such as the nose or throat, where they're less likely to cause harm. However, smaller droplets can travel deeper into the lungs and reach the air sacs. It's in these parts that the TB bacteria can begin to multiply. Some of these multiplying bacteria can enter the bloodstream and spread to other parts of the body, such as the kidneys, spine, or brain, potentially causing TB in those areas. After the bacteria enter the body, the immune system mounts a response. Within 2 to 10 weeks, immune cells typically surround the TB bacteria, forming a protective barrier. This barrier helps to contain the bacteria and prevent them from multiplying further or spreading. These granulomas can remain intact for a lifetime, keeping the TB bacteria in an inactive or latent state, which is why many people with a TB infection never develop active TB disease. However, if the immune system becomes weakened due to factors such as an HIV infection, malnutrition, or aging, the bacteria may break out of the granuloma, begin to multiply, and cause an active TB disease. Understanding this process helps explain how TB is transmitted and why some people develop active TB while others remain asymptomatic and non contagious. Understanding the difference between TB infection and TB disease is crucial, as these terms refer to two distinct stages of tuberculosis. TB infection is also known as latent stage of TB, and it occurs when the bacteria is present in the body, but the immune system is able to control the bacteria and prevent it from multiplying. In this stage, the individual has no signs or symptoms of illness and is not contagious. A person with a TB infection will typically have a normal chest x ray, and a sputum smear and cultures will be negative for the tuberculosis bacteria. The only way to detect a TB infection is through a tuberculin skin test, or TST, or a blood test, which measures the body's immune response to the bacteria. People with a latent TB infection can live their entire lives without ever developing TB disease, especially if their immune system remains strong and they do not have additional risk factors. In contrast, TB disease, or active TB, occurs when the immune system is unable to keep the TB bacteria under control, allowing them to multiply and cause illness. Approximately 5 to 10% of people with a TB infection will develop TB disease at some point in their lives, with the greatest risk occurring within the first 2 years after exposure to an infectious person. Individuals with TB disease typically exhibit symptoms such as a persistent cough lasting more than 3 weeks, fever, weight loss, night sweats, fatigue, and loss of appetite. These symptoms can begin mildly and worsen over time. A chest x ray for someone with TB disease usually shows abnormalities such as lung infiltrates or cavities, and sputum smears and cultures will often test positive for the tuberculosis bacteria, confirming the presence of active bacteria. People with TB disease are often infectious to others, especially before they start receiving adequate treatment, as the bacteria can spread through the air when the person coughs, sneezes, talks, or, remember, sings. This stage is considered a case of tuberculosis and requires immediate medical treatment to manage the disease and prevent transmission to others. So, while TB infection can mean that the person carries the TB bacteria without being sick or contagious, TB disease indicates that the bacteria has become active, causing symptoms and potentially spreading to others. Differentiating between these two stages is essential in substance use treatment settings to ensure timely referral for diagnosis and treatment, ultimately reducing the risk of TB transmission among clients and staff. It's important to understand that TB can occur in different parts of the body, known as sites of the disease. And these sites determine how infectious a person might be and the symptoms they might experience. So, first up, we have pulmonary TB, and it's the most common form of tuberculosis. This type of TB usually is infectious to others, particularly in the early stages, because the bacteria can be spread through the air when the person coughs, sneezes, talks, or sings. For example, if a client with pulmonary TB coughs in a small enclosed space, like a counseling office, the bacteria can remain in the air for hours, potentially exposing others. That's why it's crucial to identify and treat pulmonary TB promptly to prevent the spread. The second one we're going to talk about is extrapulmonary TB, and that refers to tuberculosis that occurs outside of the lungs. It can affect virtually any part of the body, such as the bones, kidneys, or brain. For example, tuberculosis in the bones might cause pain, swelling, while tuberculosis in the kidneys could cause blood in the urine. Unlike pulmonary tuberculosis, extrapulmonary tuberculosis is usually not infectious to others unless the person also has TB in their lungs. This means that clients with extrapulmonary tuberculosis generally pose less risk of spreading the infection, but still require medical attention and treatment. Miliary tuberculosis is a more severe form of tuberculosis that occurs when the bacteria spreads through the bloodstream to multiple parts of the body. This can lead to tuberculosis in various organs, such as the liver, spleen, or even eyes. Because miliary tuberculosis involves the bacteria traveling through the blood, it can be more challenging to diagnose and treat. Symptoms might not be specific and can include things like fever, weight loss, and fatigue, which are also common in many other conditions. Tuberculosis remains a critical global health issue and is the leading cause of death for people over the age of 5 worldwide. Understanding the epidemiology of tuberculosis, which includes examining both global and local statistics, case rates, and identifying key risk factors, is essential for substance use treatment professionals. This knowledge helps identify those at risk and take necessary steps to prevent and control tuberculosis spread in their settings. TB is a reportable disease in all states, which means that health professionals must notify public health authorities about any suspected or confirmed TB cases. In Pennsylvania, for example, all cases must be reported to the state health department through local health departments. This requirement extends to private physicians, clinics, and laboratories, which are mandated to report any laboratory evidence of tuberculosis. Confidentiality rules do not prevent this reporting. Public health must be informed promptly to ensure appropriate measures are taken. During the period from 1985 to 1993, the number of tuberculosis cases in the United States surged due to several factors. With the rise of the HIV epidemic, individuals' compromised immune systems became significantly more susceptible to TB. Imagine a patient, for example, who is HIV positive and has a latent TB infection. Without a more robust immune response, the latent infection can quickly become active TB, making this person contagious to others. In addition to that, many immigrants arriving from countries with high TB prevalence, such as those in Asia, Africa, South America, and Central America, brought the disease with them. Communities with high numbers of recent immigrants might see more tuberculosis cases, prompting a need for targeted screening and healthcare outreach programs. TB spreads more easily in places where people are in close, prolonged contact. Think of environments like homeless shelters, correctional facilities, IOP or PHP groups, where individuals live or work together in confined spaces, making it easy for TB to spread from person to person. An outbreak in a shelter can put not just the residents, but also the staff and volunteers at risk. During this time period, public health efforts were underfunded, limiting the ability to conduct widespread screening, provide treatment, and educate the public. This shortfall made it challenging to contain the spread of TB, especially in underserved communities. The case rate is a crucial metric for understanding TB prevalence and comparing the incidence of TB across different locations, time periods, and groups of people. The case rate helps public health officials identify where TB is most prevalent and prioritize resources effectively. The formula to calculate the case rate is on this slide, This data helps professionals understand the spread of TB in their communities and target high risk areas with interventions such as mobile testing units or community outreach programs. Certain groups of people are more likely to be exposed to TB due to their living conditions, occupations, or health status. Understanding these risk factors can help in designing effective prevention and control strategies. In addition to the previously mentioned groups, here are some other important factors to consider. Individuals who live or spend significant time with somebody diagnosed with active TB are at high risk for exposure. For example, that might be family members or roommates of somebody with pulmonary TB that can easily inhale that airborne bacteria. People who have recently immigrated or traveled to countries with high TB prevalence, such as those in Asia, Africa, South America, and Central America, are more likely to have been exposed. Community outreach programs often target these populations for TB screening upon arrival. Older adults are more susceptible to TB due to a natural age related decline in immune function. For example, in long term care facilities, residents may have less robust immune systems, making them more vulnerable to TB exposure and infection. People living in poverty or those who are homeless often have limited access to regular health care, making it less likely for them to receive timely TB screening and treatment. Crowded shelters or inadequate living conditions also facilitate the spread of TB. A case study showed that an outbreak in a homeless shelter required emergency public health interventions, including mobile clinics and on site treatment. Substance use can also compromise the immune function and is often associated with unstable housing or living in crowded, unhygienic conditions. For example, a harm reduction program might integrate TB screenings and education into its services for people who use drugs. TB can spread rapidly in environments where individuals live in close, confined quarters, such as nursing homes, prisons, shelters, recovery housing. Those working in settings where they are exposed to TB patients, such as hospitals, clinics, or community health centers, are also at a higher risk of contracting TB. Regular screenings and the use of personal protective equipment are crucial for this group. People with conditions that weaken the immune system, such as cancer, diabetes, or those who are on immunosuppressive therapy like steroids or chemotherapy, are also more susceptible to contracting TB. A cancer patient receiving chemotherapy might need regular TB testing to ensure that they are not infected. The COVID-19 pandemic has added another layer of complexity to the TB risk. Individuals who have had COVID-19, particularly those with severe cases or long term respiratory complications, may have weakened lung function, which could increase the susceptibility to TB. Additionally, COVID-19 has strained healthcare systems worldwide, potentially delaying TB diagnoses and treatment. Smoking damages the lungs, weakens the body's natural defenses against respiratory infections, making smokers more susceptible to TB. Studies have shown that smokers are more likely to develop TB if exposed and are at higher risk for poor outcomes once infected. Malnutrition weakens the immune system, increasing the risk of TB infection and progression in active disease. In settings with food insecurity or populations with high rates of malnutrition, such as refugee camps, TB cases are often higher. And finally, people with certain occupations. Occupations that involve exposure to silica dust, such as mining or construction work, can increase the risk of developing TB. Silicosis is a lung disease caused by inhaling silica dust, significantly raises the risk of TB infection. In mining communities, there are higher rates of tuberculosis that have been documented, prompting targeted screening and prevention efforts there. The relationship between TB and HIV is well documented, with several key points to understand. Areas heavily infected by the HIV epidemic often see significant increases in TB cases. These are parts of sub-Saharan Africa. The spread of HIV has been closely followed by a surge in TB cases. Between 1985 and 1992, TB cases in the United States increased most among individuals aged 25 to 44, the age group also most affected by AIDS. A case study from New York City during this period showed a sharp rise in tuberculosis among young adults as the HIV epidemic peaked. And TB is a common complication in AIDS patients due to their weakened immune systems, and HIV infection is frequently found in TB patients. This dual epidemic makes it crucial for healthcare providers to test for both diseases in high-risk populations. It's important to note that tuberculosis does not affect all racial and ethnic groups equally. Certain groups face a much higher risk of tuberculosis infection. Non-Hispanic Blacks and Hispanics of any race, Asians, Pacific Islanders, American Indians, and Alaskan Natives have much higher TB case rates compared to non-Hispanic whites. For example, Asian Pacific Islanders are 12 times more likely to contract TB than non-Hispanic whites, and non-Hispanic Blacks are 8 times more likely. These disparities are often due to broader social determinants of health, such as poverty, crowded living conditions, limited access to healthcare, and higher prevalence of TB in their countries of origin. For instance, a community health outreach program might focus on providing free TB screenings in their neighborhood with high immigrant populations to address these disparities. Tuberculosis in children is a significant public health concern, particularly because it's becoming more common in this population. A diagnosis of TB in a child often indicates recent transmission of the disease within the community, especially in the child's immediate environment. When TB is detected in a child, it suggests exposure to an infectious person who may still be actively spreading the disease, increasing the risk that others in the household or close contacts have also been exposed. Children are more vulnerable to developing severe forms of TB, such as TB meningitis, which can lead to serious complications and be life-threatening. The rising incidence of TB among children underscores the need for heightened public health efforts to prevent future transmission and protect those in increased risk. The tuberculin skin test, or the TST, is a widely used tool for diagnosing latent tuberculosis infection. It's not a vaccine, but it involves injecting a small amount of purified protein derivative, or PPD, made from killed bacteria just under the skin. The TST is used to screen individuals who may have been exposed to TB, including those without symptoms, groups at higher risk, and individuals showing signs of TB disease. This test should be read 48 to 72 hours after administration, and only the raised firm area is measured in millimeters. Redness alone is not considered. Interpretation depends on the size of the raised firm area and the individual's risk factors. 5 millimeters or more is considered positive for high-risk groups, so that might be HIV-infected persons, recent contacts of infectious tuberculosis, individuals with chest X-ray findings suggested of previous TB, and immunocompromised individuals. 10 millimeters or more is positive for those with intermediate risk factors, recent immigrants from high prevalence countries, injecting drug users, low income populations with limited access to healthcare, residents and staff of long-term care facilities, children under 4, and healthcare workers. And 15 millimeters or more is positive for individuals with no known risk factors. If you are listening to this training, you are likely in the intermediate risk factor range. The TST may yield false positive results in individuals who have other various vaccines or have been exposed to non-tuberculosis mycobacteria, and false negative results may occur in those with weakened immune systems, recent TB infections in very young children, or in advanced TB disease. And in addition to the TST, there is also now an alternative blood test that can be used to test for TB infection, especially for those who have received a vaccine or may not return for the TST reading. Remember, we have to return after the initial TST injection 48, 72 hours later. If you feel like that person won't return, you might just do a blood test instead. And once an individual tests positive on a tuberculin skin test, they will always test positive in future skin tests, as the body retains the memory of the TB exposure. Therefore, additional tuberculin skin tests are not recommended after an initial positive result. However, there are several reasons why a TST might yield inaccurate results. So, diagnosing TB disease involves a thorough multi-step process to determine if a person is infected and needs treatment. The 4 key steps of diagnosing TB are taking a medical history, collect detailed information about the patient's exposure and symptoms, ask if the patient has been in close contact with somebody diagnosed with TB, and evaluate for common symptoms associated with TB, such as persistent cough lasting longer than 3 weeks, chest pain when coughing or breathing, coughing up sputum or blood, unexplained weight loss, fatigue, general malaise, fever, and night sweats. and then determine if the patient has had a past TB infection or disease. Identify risk factors for developing TB, such as immunosuppressive conditions, recent travel to high prevalence TB areas, or living in high risk settings like correctional facilities, shelters, jails. After collecting this information, you would want to do tuberculin skin testing, perhaps a chest x ray examination, a sputum smear, taking a culture, or maybe a blood sample. Like I said previously, there are multiple reasons why there might be a false positive result on a tuberculin skin test. The first being receiving a vaccine, which is used in many countries outside of the United States to protect against TB. It may offer a false positive reaction because the vaccine can sometimes cause a mild immune response similar to that caused by a TB infection. Exposure to non-TB mycobacteria found in the environment may also cause a false positive TST test, as these bacteria can trigger cross-reactive immune response. In addition to false positives, we might also see false negatives. So that would be when somebody has tuberculosis in their system and yet the test says that they do not. So an individual may not react to the TST due to a weakened immune system, often caused by conditions such as HIV infection or severe illness, which impairs the body's ability to mount an immune response. Individuals infected with TB within the past 10 weeks may not have yet developed a strong enough immune response to react to the TST. Children under 6 months old may not respond to the TST because their immune systems are not fully developed. And in cases of advanced or overwhelming TB disease, the immune response may be too compromised to produce a positive reaction on the TST. Individuals at risk for tuberculosis are often tested upon entry to a program, workplace, or other setting to establish baseline results. High-risk individuals should be periodically retested to check for conversion, which would indicate a recent TB infection. There's a booster phenomenon that occurs when individuals, particularly older adults who were infected with TB many years ago, have had a negative reaction to an initial TST, but a positive reaction to a second test administered within a year. This is because the first test boosts the immune response, leading to a delayed positive reaction. Another thing to consider is two-step testing. So to differentiate between a boosted reaction and a recent infection, two-step testing is used. If a person has a negative reaction to an initial skin test, a second test is administered 1 to 3 weeks later. A positive result on the second test likely indicates a boosted response rather than a new infection. Healthcare providers must report tuberculosis to public health authorities when any of the following criteria are met: a positive culture for tuberculosis, so that would include laboratory confirmation, a positive smear when a culture is not available or feasible, or clinical diagnosis, a positive tuberculin skin test combined with symptoms suggestive of TB and the patient being treated with 2 or more anti-TB drugs after a comprehensive diagnostic evaluation, even if bacteriological confirmation is not yet available. So, by using a combination of medical history, diagnostic testing, chest x rays, and bacteriological exams, healthcare providers can accurately diagnose tuberculosis, ensuring appropriate treatment and public health measures are taken to prevent further transmission. Preventative therapy is a key strategy in managing tuberculosis by providing medication to individuals with a latent TB infection to prevent them from developing an active TB disease. Preventive therapy is typically recommended based on a person's age, risk factors for developing the disease, medical condition, and other considerations determined by a healthcare provider. The standard preventative therapy involves taking the medication for a period of 6 months. For children, the recommended duration is 9 months, and for people living with HIV who are at a higher risk of developing TB, the duration is extended to 12 months. It's important to monitor individuals receiving preventative therapy for possible adverse reactions, which can include nausea, vomiting, abdominal pain, fatigue, and dark urine, as these symptoms may indicate liver toxicity and other side effects. Treatment of active TB disease requires a longer duration due to the slow-growing nature of the TB bacteria. To effectively cure TB, therapy must be continued for at least 6 months. Treatment typically begins with a combination of at least 4 different medications and is confirmed that the bacteria are susceptible to the 2 primary drugs. This is a multi-drug approach, and it's essential to prevent the development of a drug-resistant TB strain and to ensure the highest chance of successful treatment. Adherence to therapy is crucial to TB treatment and can be challenging to ensure that individuals consistently follow their medication regimen. Directly observed therapy, or DOT, is often used to address this challenge. It involves a healthcare worker observing each dose of tuberculosis medication being taken by the person receiving treatment, ensuring that the full course of therapy is completed. This strategy may require flexibility, such as providing therapy at a location most convenient for the individual. While DOT places the responsibility for ensuring adherence on healthcare providers rather than the individual, which may differ from the patient-centered approach often emphasized in substance use treatment programs. Accepting this method is critical for controlling and ultimately eliminating TB. To further support individuals in adhering to their treatment, the use of incentives and enablers can be highly effective. Incentives such as providing food or clothing may encourage individuals to continue their therapy, while enablers like transportation assistance, such as cab fare, transit tokens, may help them attend appointments. These supports should be personalized to meet the unique needs of each individual, helping them complete their treatment successfully. And patient education is also essential to help individuals understand the nature of tuberculosis and the importance of completing their treatment regimen. Education should be comprehensive and consider the whole person concept, addressing the individual's overall well being, including physical, emotional, and social needs. In some cases, it may be necessary to make referrals to appropriate services such as social services, housing programs, or community resources to provide additional support. By adopting a holistic approach to TB treatment, healthcare professionals can improve patient outcomes and contribute to the goal of eliminating TB in the community. Several factors can increase the likelihood of a person with tuberculosis will spread the bacteria to others. The site of disease is particularly important. Like we were talking about before, individuals with TB in the lungs or pulmonary TB or throat TB are most likely to be infectious because the release of bacteria in the air when coughing. Coughing significantly contributes to the spread of the TB bacteria, especially if the person is unwilling or unable to cover their mouth. Additionally, a person who has been on an inadequate therapy regimen defined as less than 2 to 3 weeks of effective treatment or who shows no clinical improvement is more likely to be infectious. Children with TB are much less likely to be infectious than adults. This is because children typically have a lower bacterial load in their sputum and do not cough as forcefully, reducing the risk of spreading the bacteria through the air. However, children are still at risk of becoming infected if they live in close contact with an adult who has active TB. To prevent the spread of TB, it's essential for healthcare settings to implement an effective infection control plan. Key components of this plan include early detection of TB disease and the prompt isolation and treatment of anyone suspected of having TB. If TB is suspected, the individual should be placed in an area away from others, preferably in an isolation room. They should wear a surgical mask covering their nose and mouth and use tissues to cover their nose and mouth when coughing or sneezing, even when in an isolated area. In emergency situations, a temporary negative pressure room can be created by opening a window and using a fan to blow air outside while keeping the door closed, which usually helps draw potentially infectious air out of the room. This method should only be used in emergencies and is critical to contact the person's physician or local health department as soon as possible for a thorough evaluation and guidance. Healthcare staff play a vital role in TB control by recognizing the signs and symptoms and knowing how to manage somebody who may have undiagnosed tuberculosis. Staff can support the treatment process by providing encouragement and assistance to the person receiving care, identifying when additional support from other agencies may be needed, and participating in directly observed therapy if requested by the health department. Through these efforts, healthcare workers significantly contribute to preventing the spread of TB and ensuring that individuals with TB receive the appropriate care and support they need. Thank you all for being here today and digging into the ins and outs of tuberculosis with me. I know tuberculosis might not be the most exciting topic, but it's so important for the work that we do every day. We covered a lot of ground, from understanding the difference between tuberculosis infection and tuberculosis disease to figuring out how it spreads, what makes somebody more or less infectious, and how we can help prevent it. We also discussed how crucial it is to catch symptoms early, support our clients through their treatment, and use effective infection control measures. Remember, this was just the first part of our 3-part training series. Next time, we're diving into the world of sexually transmitted diseases. Thank you for your attention, your hard work, and your dedication to keeping our community healthy. And remember, when it comes to knowledge, sharing is caring. But when it comes to tuberculosis, let's not share. So there's a link to the quiz below this video. Stop here, click the link, take the quiz, and then we'll move on to the other videos.